Rolling?
Rolling.
All right. Hey, everybody, it's Lou Malino. I am here with one of my patients who will remain out of the picture and anonymous, trying to give everybody a better understanding of how to explain advanced cholesterol testing to patients. So she is sitting in front of this lab sheet. So Susan, what we do first is we review the traditional cholesterol profile. We've all heard of total cholesterol. Yours is 175. Historically, we look for a value under 200, although I'm going to tell you in a second that none of these traditional cholesterol measures really matter anymore because we check much more advanced testing. Your LDL cholesterol, which is right here, has historically been known as the bad cholesterol. And in someone with risk factors like you, we like to see that value below 100, and a value of 79 is absolutely perfect. HDL, the good cholesterol, high-density lipids, we've historically thought of as the good cholesterol. The more of it, the better. We now know that people with high HDL cholesterols like you, a value over 60 and yours is 74, is beautiful. But we do see some heart disease in that population because super high HDLs are sometimes not great. HDL behavior is what matters, and we're starting to test for that now. But this is a great number. Triglycerides are circulating fats in your bloodstream. They are another type of bad cholesterol. High numbers here predisposed to heart disease, and a value below 90 is what we consider the sweet spot, perfection. And a value of 83 indicates very low cardiac risk, which is great. Even though they're circulating fats, they don't go up when you eat fat, they go up when you eat carbohydrates. So when we see high values for triglycerides, we ask patients to drop their carbohydrate intake. Here's the advanced cholesterol profile I was talking about. It's called a VAP. The most important number on the page is called the ApoB. The ApoB is another way of saying how many cholesterol particles, dangerous cholesterol particles there are driving around all your bad cholesterol and illegally dumping it in your arteries. The number of particles is a much better marker of future cardiovascular risk than any other measure on this page. So if I had to explain it best, I don't know if you can see this white sheet of paper, you have a bad cholesterol of 79. We'll make it 80 so that it's easy to understand. So this is 80 milligrams of bad cholesterol. It can be driven around your body in two ways. One way is you could have 80 1 milligram particles driving it around. Add them all up, you have 80 milligrams of bad cholesterol. The other way is you could have two big particles that each carry half of it around. Each of these particles, no matter how big or how small, have a protein attached to it called an ApoB. Even these little ones, they all have one. If we count the number of ApoBs, we are counting the number of nasty cholesterol particles in circulation, the artery cloggers. So your value is 72. And what I do is I look at this sheet here. You got that in focus? Mm-hmm. So ApoB, which is another way of looking at the number of bad particles, a value of 72, I find it on my sheet, it's right about here. Follow it all the way over to the first column. This puts you in about the 13th percentile compared to the rest of the population. This means that your numbers are better than 87 out of 100 people. Anytime you're below the 20th percentile, based on the American College of Cardiology, you are at low risk. So these are beautiful numbers. The 5 milligrams of Crestor is doing an absolutely perfect job. What I also look at is the ratio down here of bad particles, artery cloggers, to ApoAs, which is right here, good cholesterol particles. The more of those, the lower the cardiac risk. And we want to see a ratio here under 0.6, which is considered optimal. And a ratio of 0.43 is a great sign that you are at low cardiac risk. There's one more thing we look at, and it's called LP little a, lipoprotein little a. This is something you're either born with or you're not. You were born with not a high amount, but sort of an intermediate risk amount of LP little a. And in English, this is a protein that circulates around your bloodstream, and it binds to these ApoB particles. It attaches itself just like this. and it jackhammers them into the artery with greater efficiency, and they don't belong in the artery. So when we see high levels of Lp(a), we are looking at someone who is at higher cardiac risk because their nasty particles are more apt to gain entry into the artery where they don't belong. There are drugs to treat this. There's a drug called niacin, but treating it does nothing to lower cardiac risk. So what do we do to treat this? We lower the cholesterol particle number, the ApoB, to below the 20th percentile, which we've achieved in your case. So this is in goal range for somebody with a high Lp(a). And the last thing we look at, because half of heart disease is about cholesterol particles, and the other half is about how your arteries are behaving. Are they inflamed, which means they're more apt to fill up with plaque, or are they not inflamed? We do an inflammatory marker that's specific to the arteries in the heart called myeloperoxidase. When myeloperoxidase is high, it means that there is active or vulnerable plaque in the coronary arteries. That is our marker for short-term cardiac risk. And by short-term, I mean over the next 6 to 12 months. If this number were up, it would be a sign that you're at higher risk. We would do things like move up the dose of your Crestor, add more aspirin, add fish oil, suggest a low-carbohydrate diet, suggest more exercise, things like that. But in your case, the number is absolutely perfect. We're looking for under 320, which is a sign of low risk, so you don't have any sign of artery inflammation, and therefore your short-term risk is low, and your long-term risk, in my opinion, is low, which is great. So I think we can stop there.